Many of you are tired of prescribing calf stretch after calf stretch to only find little to no results. Well, if this is the scenario, we need to ask ourselves different questions to get different outcomes. So in this video, I want to address why our patients and clients continue to have tight calves even after they've done stretch after stretch, and 4 simple exercises that you can start to use to start to fix the source of their calf tightness. To make sure we're successful in the 4 exercises that I'm going to demonstrate, let's take a step back and understand the biomechanics and what's really causing the source of this calf dysfunction. Let's start at the ribs and the spine. Usually, patients and clients that experience chronic tight calves are going to have a rib cage that is flared up and a spine that is more in extension. And as we continue down to the pelvis, they're going to be in more of an anterior pelvic tilt. This is when the sacrum tips forward, the innominate bones go in extension, and we usually refer to this as someone that has an increase in lumbar lordosis. Now, as we continue down to the foot, what's going to happen is instead of really starting from the heel, and if you think about the gait cycle, going from your heel to your midfoot to your toe, or your early stance, mid stance, late stance, a lot of these individuals are actually starting at the mid stance phase. And this is a direct outcome from their pelvis position and the rib cage following above. So they're not starting with this nice heel contact. Every time they go in step, it's more of a midfoot and toe off. And I'm sure you've seen these patients or clients in the clinic or the gym, and you might have even heard them because they're typically a little bit louder when they're walking. They're trying to keep up, they're going through these cycles, and it's a lot, and they're doing the best that they can. So there's ultimately going to be 2 main consequences at the calves that keep them tight. The first one we already talked about, and that is that this person is starting in an anterior position or forward, which is not allowing them to get their normal gait mechanics. So instead of going from heel to mid to toe, this person is constantly going mid to toe, every step that they're taking. What this is doing is this is essentially putting them in a calf raised position. They're kind of living on the anterior side of their foot, their forefoot, and the calves are going to respond. They're being overworked. This is when they're tight and achy and feel like they're always on, and that's why patients or clients go to stretch them, but they're not getting the relief because they're not fixing the true source of the problem. The second thing that happens is because of the anterior pelvic tilt at the pelvis, it's going to create a natural elongation and stretch effect on the calves. Again, if you go into that anterior pelvic tilt position, you can feel a little bit of calf stretch as you go into that. So I totally understand why patients try to stretch because it helps them feel good for the moment. And I know as a physical therapist or a personal trainer, it's an easy strategy to do to give them that temporary short-term relief. But based off the principles we just talked about, hopefully you can see that to fix the source, we actually need to fix the position. The anterior pelvic tilt, the flared rib cage, the midfoot position are all contributing to the calf having to work way more than it should and put it in a position where it's constantly stretched, which gives them that chronic tight calves. So what we want to do is change the position. We want to get them to shift back. We need the rib cage to come down, we need the pelvis to be able to go in the posterior direction, and we need them to be able to feel and sense their heel. So the first exercise we can do is a passive range of motion deep squat. It's a super simple exercise, but helps your patient or client feel that posterior direction without really having to work for it. So all you'll need is a TRX, you can use a barbell, you can use a door, something that's going to support them. And all you're gonna do is have them put their feet all the way together. They're gonna push their knees forward as they go down. They're gonna go in this deep squat position, and we need to keep the heels on the ground. If your patient or client struggles to keep the heels on the ground, add a slant board for a heels elevated position. From here, just cue them to do 4 to 5 breaths in this position with their head down. The breathing should be relaxed. You shouldn't really see them breathing. Everything should be calm, and all we're trying to do is get their pelvis to go in that posterior direction. The next exercise you can do is any sort of posterior pelvic tilt. So the classic is a dead bug, but anything that's going to require your patient or client to hold their pelvis in the posterior direction as they're moving a leg or an arm. The next thing you can do with this is add a reach. The reach is going to help that posterior pelvic tilt, and it's also going to help to get the rib cage to go down and in. So for a normal dead bug, all you're going to do is cue your patient or client to go in a hook lying position, cue them that they have a big belt buckle on, and the belt buckle needs to go towards the chin. From here, they need to focus on the pelvis and not get caught up in the distractions of the legs or the arms. With a good dead bug, we hold on to that posterior pelvic tilt, we bring one leg up, we bring the other, depending on the level of their fitness, and then you can do different things from here, moving the legs, moving the arms, reaching to get that retraction, moving the arms and legs. I don't really care what you do, it's more about understanding the principle of we first went to a passive range of motion for the posterior pelvic tuck, and now we're getting it in an active way. The next exercise is a foam roller isometric hamstring. The goal of this is to start to bias compression. Now what I mean is that in a posterior pelvic tilt, the same goal that we've been trying to get throughout this whole video, what needs to happen during a successful tilt is that we need to get compression on the backside. Those that are in an anterior pelvic tilt, they have too much muscle length back here. So think about the muscles being back here and just think about too much length and not enough compression or strength. So with this exercise, what we're trying to do is get the glutes and the hamstrings just to start to compress and learn how to take control of the pelvis and push it in that posterior direction. So all you'll need for this is a foam roller, and you can have your patient or client go on with or without shoes, ideally a mid-foot position, right? Because we're trying to bias that mid portion. We can put a ball between the knees to help a little bit with the adduction. And all we're going to coach our patient or client through is to go through their tuck so they know that belt buckle towards the chin. We're going to raise up and maintain our posterior pelvic tilt. I already feel the hamstrings. Then we're going to start to pull the heels back. Again, that should kick the hamstrings in more. Then you can figure out how high can I go where I'm still maintaining my hamstring tension. All we're going to do here is hold for 60 seconds, make sure that the hamstrings are staying on and they're staying in that posterior pelvic tilt. The last exercise we're going to go through for tight calves is a heels elevated squat. You can use a TRX, you can go in a goblet position, and whatever you feel is best for your patient or client's needs. I would suggest an anterior load and use of the slant board so it can help to go into that posterior direction. The slant board is going to bias external rotation and plantar flexion at the foot, which is going to help us achieve that posterior orientation of the pelvis that we're looking for. All we're going to do is make sure that our patient or client stays on that slant board, and we're really going to cue them to go down like an elevator, so not an escalator. Patients and clients that experience tight calves are usually better at pushing back. Instead, we're going to really cue them to push their knees forward and to sit straight down. And as they go down, they should feel like they're going very vertically like an elevator, and it might feel weird to them while maintaining that heel contact, not letting them pop up off the heels. So again, it's really important as they go through it, the knees go forward and they go straight down compared to seeing them push back. From there, you can have them hold at the bottom if you want, and then you can start to increase the intensity once they understand how to move vertically like an elevator.